Now look at our mode menu here on the left-hand side. Remember, we're in the missing teeth mode now. It's highlighted. We had recession turned off in those initial visit settings. It's grayed out. We're going to skip it, and it's going to automatically move into the next mode that's selected, which in this case is pocket depth. So if I'm confident, I advance.
Upper arch, entering pocket depth.
It moved into pocket depth, and I'm ready to begin the exam. Now, the cursor is on the distal buccal of 1. So I'm ready to begin with the patient. Take off my protective cover. And I've already made my first mistake. My patient doesn't have 1 and 2, and I had 1 and 2 left in here. I've left the mode. I can't fix it with the foot pedal. However, those keyboard shortcuts are going to rescue us again. I can use the butt end of this encoder cable to help maintain asepsis, and because the cursor is on tooth 1, I just hit delete.
Missing.
And it takes it away. So it's not the end of the world. We can fix it. It's all those keyboard shortcuts, which I encourage you to post so that you can refer to them. 2 is also missing, and I can use my arrow keys to advance over, hit delete,
Missing.
and it's gone. Or I can advance with the foot pedal. Either way. That usually happens the first time with your first ortho patient, and the first bicuspid is gone, and you get to tooth 5 and it was really missing. It's a great shortcut to just reach over and hit delete. Okay? So it's not the end of the world. The cursor is now on the distal buccal of 3, and that's where we're going to begin the exam. So just like I did your fingernail, I insert the tip to the bottom of the pocket. I contact the free gingival margin with the sleeve of the probe, just like I did the end of your nail, and I step on the center foot pedal when in contact with the margin.
6. 2.
Advance to the next site.
Warning. 4. 1. 1. 2.
And it's automatically advancing. Now notice that tooth 6 here is an implant. This is an implant grade titanium tip, so I can probe around implants. There's no dissimilar metals. I only want to determine, the doctor to tell me at what maturity, how old does it need to be before he wants it probed. So if I don't want to probe it, as long as I'm not measuring, I can just quick tap with the foot pedal and advance beyond it. Put my cursor on the distal of 7, and that's where I resume probing.
1. 3. Warning. 4. Warning. 4. Danger. 7.
Now you notice there are warning and danger levels. Those are definable parameters within the options. I currently have mine set at 3.4 millimeters, enunciates the warning, and 5.4 millimeters enunciates the danger level. That's really the power, that the patient is hearing the computer tell them about those warning and the danger levels. While in the pocket depth mode, I'm using the side pedals on the foot pedal. The red one, when I observe bleeding on probing, I step on it.
Bleeding.
The computer enunciates bleeding. When I observe suppuration, I hit the yellow pedal.
Pus.
Now I can make, in those options, under the sound options, I can enunciate suppuration, pus, or exudate. You notice I had this one turned on to pus, and I submit that patients understand what that means. If that's the point, let's use language that they understand. Patients don't necessarily understand what suppuration is, so I have mine turned on to pus.
Warning. 4. 2. Midline.
And also notice that it enunciated crossing the midline. That's going to help you keep on track throughout the exam so that you're not going to be off any more than a quadrant at most. It's also very helpful to have this computer where you can refer to it easily. Not only for the patient to see it, but for you to be able to refer to it. If it's behind you and you're doing a big motion to see it, ergonomically is not going to help you. It's better to be able to just lift your head and have it in a position where the patient can see it. Now notice that we have probed the mesial of 9 and the cursor is still there. It's waiting there. It will automatically advance when I take the next measurement.
1, 2,
Will auto advance, but it's waiting to see if there is bleeding or suppuration.
Can I turn those warning levels off?
Certainly. In the sound options, not only can you turn them off, will it speak in 14 different languages, male or female voice, but we can also make it a sound effect. I think I understand where you're coming from, that you're concerned about upsetting your patient or perhaps damaging your rapport with them. It really helps your rapport with the patient because you're not delivering the message to it. The authoritative computer is. And it actually insulates you from delivering that bad news. It helps you because you can say to the patient, it's okay. We can help you. The good news is we caught it early. The good news is we have non-invasive therapies. There's a lot of positive here in allowing the computer to deliver that message. Do you feel pretty comfortable with pocket depth at this point?
2,
Do you have any
2.
questions?
What if I make a mistake?
Good. There are 4 very common mistakes, and they usually happen in exactly this order. The first one is, I'm probing a healthy patient.
2, 3, 3,
And all of a sudden I hear something like,
danger. 8,
is that possible? Sure, but the point is I want to reconfirm it. So number 1, I heard it instantly, and I want to reconfirm it. The little round button at the top of the foot pedal is an undo button. Think of it as a backspace bar. So I simply hit it, and I can reprobe that site. And I can use the undo button up to 10 times. More important than fixing it is understanding why it happened. What generally happens for a new user especially is they've simply gotten too fast on the foot pedal. I can walk that sulcus with the probe as long as I want. It's not until I come into contact with the margin and step
warning. 4,
does the computer take the
3.
measurement. So if you are still traveling with the sleeve and you are not in contact with the free gingival margin yet,
danger. 9,
usually happens from just getting too fast on the foot pedal, stepping too soon. So I undo and undo up to 10 times and reprobe that site, making sure that I am in contact with the margin.
3,
So that's the first common mistake. The second common mistake is I'm probing a periodontally involved patient.
warning. 4, warning. 4, danger. 6,
And all of a sudden I hear something like,
1,
is that possible? It is, but I want to reconfirm it. So I simply undo and reprobe that site. But what could cause that? Remember, this is a 15-gram constant force probe. It stops at the resistance of 15 grams. So if there is subgingival calculus, if there's a crown margin or some other tooth anomaly that catches the tip of that probe, it's going to stop at that level. We need to make sure that we find the true bottom of the defect. So this little blue button on the top of the handpiece is a frictional override of the constant force pressure. It turns it into a traditional probe. So now I can use that blue button, go through that or by that calculus ledge, by that crown margin, find the true bottom of the defect, then let go, contact the margin, and take my measurement.
danger. 8,
That's the second issue relative to patient comfort. Because there's a blue button, it's almost intuitive to pick it up and put your finger on it. I don't want to rest my finger on the blue button because that overrides the 15 grams pressure. Nor do I want to interfere with the travel of that arm, especially as you fulcrum in different manners around the mouth. Third common mistake, you simply misstep on the foot pedal and hit,
bleeding.
and you didn't mean to. Those bleeding and suppuration pedals are on-off switches. So all you have to do is hit it again, and it goes away,
Bleeding.
goes away,
Bleeding.
goes away. I don't even have to go to the undo button. So the first three are, you get an artificially deep pocket, you want to reconfirm it, something didn't sound right when you heard the computer delivering the message, undo, reprobe, making sure that you're in contact with the margin. Generally speaking, you just stepped before you were in contact with the margin. Secondly, you're probing an involved patient, you get too shallow, even a 0 will enunciate. Undo, use your blue button, make sure you're at the true bottom of the defect, then take your measurement. Third one is simply misstepping on the foot pedal. And in a few minutes, we're going to work on the ergonomics of the foot pedal to minimize those mistakes and minimize fatigue with you over the course of using it for the day. The fourth one is really not a mistake, but I use it most applicably for delayed bleeding. I'm on and have probed the straight lingual of 15, and I had delayed bleeding on the mesial buccal of 13. I want to record that bleeding. I want to maintain asepsis and work solo. I can move there with the foot pedal. I could use my undo button, but I'd have to redo all that work, which is not what I'm after. What I'm really after is to move that cursor to the mesial buccal of 13. So what did quick taps on the red pedal do? Recorded bleeding, on and off as a toggle. Remember, there's 2 strokes. Quick taps, hold and listen. Quick taps recorded bleeding,
Bleeding.
but hold and listen puts me into a moving mode.
You are in the moving mode.
Now I'm in a moving mode, and I may use my side pedals to go forward and back. Don't think of it right and left. Think of it as forward and back. Put it on the aspect of the tooth that I want, mesial buccal 13, and the center pedal puts me back into the mode from which I came. I was in pocket depth mode. It's putting me back in pocket depth mode.
Entering pocket depth.
Now I can record my bleeding
Bleeding.
and use the center pedal to advance without changing data. As long as I'm not measuring, I'm not changing data. But even if I wanted to reprobe a site, I could put the cursor there with the moving mode and reprobe it.
Warning. 5.
Some people will probe the buccal aspect of a quadrant and go back with the moving mode and pick up their bleeding points. I'm not suggesting that that's the most efficient use of your time. Some people will do it, and the moving mode is how to do that. If you'll slow down just a microsecond while you're probing, most bleeding will manifest on probing before you move to the next site. Let's review that moving mode just one more time quickly. Hold red pedal,
You are in the moving
puts
mode.
us into a moving mode. Use side pedals to move forward or back in the mouth. Go to the most distal from where you are, and center pedal puts you back into the mode from which you came.
Entering pocket depth.
And you can record bleeding or take a new measurement.
Bleeding.
Use your center pedal to advance
Bleeding.
and pick up those bleeding points. End up putting it back where you want to resume and resume your probing.
Warning. 4. Warning. 4.
So those are the four common mistakes that we do. When we trade places and you actually have the chance to play with this, it'll be a lot easier for you, make a lot more sense. Any other questions?
No.
Okay, let's move on. I'm going to move us on manually with my arrow keys. Remember I said at the end of
Pus.
the
1, 2, 2, 2, 2.
each mode, I pause. It's a good time to rinse, suction, let the patient close their jaw, and do a quick review. Am I confident that I've recorded pocket depth correctly? If I am, I advance. Now this took us to a new submenu. It says some sites have very low or no pocket depth recording. Do you want to reprobe these sites? Well, you and I are playing around. I skipped a lot of the mouth. So I might say, no, I don't want to go back. But had I probed the entire mouth, I would want to say yes and reconfirm those zeros. It doesn't make me
Upper
reprobe
arch. Entering pocket depth.
the whole mouth. It only takes me to those zeros. So in this instance, it took me to the distal buccal of 6, which was the implant that we knowingly skipped. So I'll skip it again. And it went to the next 0. So it's not making you reprobe. It's a very useful tool if you've conducted the whole mouth exam.
2, 2,
This time I'm going to say no to that because I know that we've skipped a lot.
upper arch, furcation.
It now moved into the next mode that was selected in the initial visit settings, in this case furcation. Now I'm not using the Florida probe handpiece to measure furcation. I can lay it down on my tray. Some people put it on the patient's bib. I'm using my neighbor's probe, and I'm doing exactly the same exam that you've always done for furcation, just you are using the foot pedal to record, maintain asepsis, a class 1, 2, or 3 of furcation. So the cursor is currently on the buckle of 3, quick taps advance,
Midline.
it skips all those single rooted teeth, it skipped 5 and 12 because they're missing, and it went to the next multi-rooted tooth, which in this case is the straight buckle of 14. If there is furcation involvement, I hold and listen.
1, 2, 3. 1, 2.
When I hear what I want, I release.
1, 1, 2, 3.
If I've made a mistake, my undo button still works. To undo the last thing, up to 10 times.
1,
Quick taps advance,
midline.
hold and listen.
1, 2, 3.
My moving mode works, just works within furcation mode at this point. The graphics are very easy to follow. The concavity and the convexity of the teeth indicates buccal or lingual. Quick taps advance, hold and listen.
1, 1, 2, midline. 1, 2, 3.
I'm going to advance to the lingual of 32, and again, pause, do a quick review. If I'm confident with the furcation mode, then I'll advance.
Upper arch, black.
And it moves into the next mode selected, in this case, plaque. You're going to do exactly the same exam that you've always done with plaque. Whether you disclose, you're going through with just a scaler and checking, explorer and checking for plaque, you're simply using the foot pedal to record the presence of plaque. So quick taps advance, very consistent, hold and listen.
Black, black, black,
Quick taps advance, hold and listen.
black,
Now, let's be clear,
black, black, black. Midline.
I'm going to advance this with the arrow key.
Black,
Plaque is really 4 sites per tooth. Even though on the buccal aspect here it's recorded as 3 and 1 on the lingual, that's because as we're conducting the buccal pass, we collect the interproximal data. So when we come back on the lingual pass, we're only doing the straight lingual. Does that make sense? A very useful keyboard shortcut. If the patient presents with just generalized plaque, Control Q will put plaque everywhere. And if I don't want to record it on 128 sites, that's a great little shortcut. And I'm finished, so I can use my end key
mobility.
to leave the mode, take me into the next mode selected, and move on. Great keyboard shortcuts, especially in that mode. We're now in the mobility mode. You're going to, again, do exactly the same exam you've always done. Starting at 2, 3 in this case, in the upper right, quick taps advance, hold and listen.
1, 1, 2, 1, 2, 3.
And you're recording class 1, 2, or 3 mobility. Quick taps advance and record a 0. I get to tooth 15, I pause. Am I confident in the upper arch? If so, I advance.
Lower arch.
Where'd the cursor go? Always refer when we change arches. In this case, it went to 18. That's different than a multi-aspect pass. The path is not definable within the software. So part of that strategy is to refer to the computer and see where that bright orange cursor is. Because mobility is not buccal and lingual, it went straight from 1 to 16 and dropped straight down to 17 and coming back. Whereas where there are multiple aspects, it changed the pattern. I get to the end of mobility, pause. Am I confident? Because I can fix anything within a mode using the foot pedal. Undo, moving mode. If I'm confident, I advance. And it takes me to the next mode selected. In this case it's the patient diagnosis. I can turn this mode off in the initial visit settings. I can select no diagnosis, which is the default here, or I can use my side pedals, as the graphic indicates, to navigate that menu and highlight a specific diagnosis. In this case, I'll use moderate. Select with the center pedal.
Data collection complete.
And we get a dialog box that says, do you want to save and print? I prefer to think of this as, is the exam complete? If the exam is complete, I want to save and print and I'm done, yes. If I'm not finished, let's say for example, I conducted that pocket depth, furcation, plaque, and mobility exam, but noticed that the patient had recession and it was turned off in the initial visit settings. So I can say, no, I'm not finished, and it takes me to a mode select. Even though I had recession turned off, I can still highlight it using the side pedals, select it with the center pedal.
Upper arch, recession.
It turned it on and took me there. Now, special deal with recession. I can do recession at one site on the straight buckle, 2 sites, 1 buckle, 1 palatal, or do 6 sites per tooth and map the recession. If I do 6 sites per tooth, then I can do pocket depth and recession in the same pass. We call it speed pass, and that's set in the initial visit settings. I don't start there. It's a little more technical to do, and I'll show it to you after a while. Right now I'm only set to 1 site on the straight buckle. So on my patient, the first significant recession I have is tooth 11. I'll use the foot pedal to advance the cursor to tooth 11, and now by definition, recession is the difference between where the free gingival margin is and where it should be at the CEJ. So it's a 2-stroke measurement with the foot pedal. Just like pocket depth, I insert the tip, contact the margin, and step once, telling the computer where the margin is. Then I let the sleeve out to the CEJ and step again,
Warning, 3.
telling the computer where the CEJ is, and the computer does the math. Gave me a 3 millimeter of recession. Let's put the cursor on 14 and do another. We insert the tip, contact the margin, step, let the collar out to the CEJ, and step again.
2.
The computer enunciates it, does the math. Now,
Lower
we also
arch.
do hyperplasia. So I'm always measuring the free gingival margin first. Now the CEJ is below with no attachment. I feel the CEJ with the sleeve,
Hyperplasia, 2.
and the computer enunciated hyperplasia, shows the pseudo pocket, and pocket depth is going to be measured from the free gingival margin. And it recorded it as a negative number. So when we're calculating true clinical attachment loss, it is using the negative number, and as hyperplasia resolves, the CAL will be the correct measurement. Questions about recession?
No.
While in the recession mode, the side pedals are
Minimal attached gingiva. No attached gingiva.
and no attached gingiva. We can do that, or we've actually added an MGJ mode now. Let's look at it. I advance to the end of recession. Good strategy, pause. Am I confident I've recorded recession correctly? If so, I advance.
Data collection complete.
Is the exam complete? No. Let's go back and do the MGJ. So I say no. Use my side pedal to highlight the MGJ mode, select it,
Up.
and it turned it on and took me there. Now, I can do the mucogingival junction measurement with a standard probe and record it with the keyboard, or I can use the Florida Probe handpiece to do it. Cursor's on 3. I'm going to start there. I need something to mark where the mucogingival junction is. I can use a mirror, but that tends to be pretty invasive on the gum tissue for the patient. Prefer to use the gloved finger to mark where the MGJ is, and it acts as the stop for the tip. And now I move the collar to the margin
6, 7,
and record the MGJ. It's just a lot less invasive on the patient to record and retract with my gloved finger. So do you have any questions about the MGJ mode?
No.
Okay, well, let's advance through.
lower arch,
Now at the MGJ, the end of the MGJ mode, and there is a lingual aspect on the lower arch, I pause. Am I confident? I advance.
data collection complete.
This time, is the exam complete? Yes, we've done all the modes. So I say yes. It's now saved to the database, and it's taken me to my print options.